Welcome to The Explainer. Today, we're going to do something a little different. We are throwing you right into the hot seat, the final exam for a surgeon. You're the candidate, and you're about to face a case that's going to test everything you've got, your knowledge, your logic, and yeah, your nerves.
Picture this. You're in that final exam. The door closes, the clock's ticking, and bam, your first case is a neck swelling. So, how are you going to pass this? All right, let's begin. Okay, here's the scenario. A 42-year-old female, otherwise totally healthy, comes to you with a neck swelling she's noticed for about 3 months. What's the first thing that pops into your head? Okay, so given the location in the front of the neck and the patient's age and gender, my primary differential, my working diagnosis, is a thyroid nodule.
Good. Thyroid nodule it is for now. So, what questions are you going to ask this patient? Let's build out the history. Well, my approach would be really systematic. First, I need to rule out any red flags for local invasion. So I'm asking about things like hoarseness, difficulty breathing, or trouble swallowing. Next, I'm going to check on hormonal function. Symptoms of hyper or hypothyroidism. And finally, and this is crucial, I'm digging for risk factors for cancer. So has she ever had neck radiation? Is there any family history of thyroid cancer?
Excellent. Let's say the history is completely clean, non-contributory. Now, you examine her. What are you looking for?
My exam has two main parts. First, I'm focusing on the nodule itself. What's its consistency? Is it firm? Is it mobile? And of course, does it move when she swallows? That's the classic sign. But just as important, the second part. I'm carefully feeling for any swollen lymph nodes in the neck. If I find any, that's a big deal. Really raises the suspicion for cancer.
Okay, you have your history and your exam findings. Give me your differential diagnosis. Really, the differential diagnosis boils down to one huge question. Is this benign or is it malignant? On the benign side, you've got things like cysts, adenomas, or just inflammation. On the malignant side, you're thinking about the big four: papillary, follicular, medullary, or anaplastic cancer. The whole point of the workup is to figure out which camp this falls into. Logical. So what's your plan? How are you going to work this patient up?
The workup is pretty standard. It follows a 3-step ladder. First, a TSH level. That blood test tells us if the thyroid is working normally. Second, we get a thyroid ultrasound. That's our eyes on the nodule. We get to see its characteristics. And third, based on those first 2 steps, we move to the big one, an ultrasound-guided fine needle biopsy.
Okay, so the TSH comes back normal. Here's the ultrasound report. It says there are several suspicious features. What kind of features are we talking about? On an ultrasound, certain things just scream, be careful. For example, if the nodule is hypoechoic, meaning it's darker than the rest of the thyroid. Or if we see microcalcifications, those are tiny little specks of calcium that can be a red flag. Irregular margins are another big one. It looks like the nodule doesn't have a clean border. Maybe it's trying to grow into the surrounding tissue. Exactly. So with those suspicious features on ultrasound, what's the absolute single most important next step? The definitive next step is an ultrasound-guided fine needle aspiration biopsy, or FNAB. No question, this is the most important tool in our toolbox for this. Okay, you've done the biopsy, the report is back, and the pathologist calls it a follicular neoplasm. This right here, this is the moment the whole case pivots. Okay, let's pause the exam for a second because this is where things get really interesting. You have to understand a follicular neoplasm isn't a clear yes or no for cancer. It's the ultimate gray area. The pathologist looks at the cells from the needle biopsy and says, yep, these are follicular cells, but I can't tell you if they're from a benign adenoma or a malignant carcinoma just from this sample. It's an indeterminate result.
So what's the significance of that diagnosis? What does it mean for the patient? It means there's a 15 to 30% chance that when we take the whole thing out and look at it under the microscope, it's actually going to be cancer.
Okay, with a 15 to 30% risk of malignancy, what are you going to do? What's your management plan? The standard of care here, the correct answer is a diagnostic thyroid lobectomy. That means we go to the operating room and remove the entire half of the thyroid that has the nodule. What's so clever about this is that the surgery is both the treatment and the final diagnosis. We have to give the pathologist the whole nodule to know for sure. So in the OR, we start by positioning the patient with their neck extended. I'll make what's called a Kucher incision right in a natural neck crease so the scar is less visible.
Then we carefully divide the platysma and separate the strap muscles to get down to the thyroid. First order of business is getting control of the blood supply, so we'll find and divide the middle thyroid vein and then the vessels at the upper pole. Now, hold on. Here is a huge point. In the exam, the examiner is just waiting for you to say this next part. This is the single most critical safety step of the whole operation. If you damage this nerve, the recurrent laryngeal nerve, your patient could have a permanently hoarse voice. So you have to say you're going to find it and protect it. It's non-negotiable. Okay, so once that nerve is identified and safe, we also have to find and protect the parathyroid glands. They're tiny, but they control the body's calcium, so they're super important. Only after those structures are safe do we actually remove the thyroid lobe. Then it's all about making sure there's no bleeding, what we call hemostasis, and closing everything up in layers. Afterwards, of course, we're watching the patient closely for any voice changes or signs of low calcium. So let's break down how you pass this station. It's all about showing a structured, logical, and above all, safe thought process. You've got to show you can go from A to B to C. History, then exam, then workup. You have to know what else it could be. And you have to know the game plan for every possible biopsy result, especially that tricky follicular neoplasm. And the big one, you have to actually say out loud the critical safety steps, like protecting that nerve. And just like that, you've passed the station. You navigated the case perfectly. But for the real patient, the story isn't over. Because what happens if that final pathology report comes back and it is cancer? Well, that opens a whole new chapter. It often means going back for a second operation to remove the rest of the thyroid, and then having conversations about radioactive iodine therapy and a lifetime of follow-up. The exam is over, but the patient's journey is just beginning.